Hi, this is Fernando Gomez Sancha, and this case, we recorded it in the operating room, and I thought I was also recording the audio, but I forgot to turn it on. So for the duration of the operation, I was commenting on it, but it couldn't be recorded. But it's a rather interesting case, and I thought it was worth uploading it to my YouTube channel. And so I decided to do a voiceover of the video. This patient is an 84-year-old man. He had a retention of urine with a 2-liter residual and was wearing a catheter. They couldn't remove the catheter, and he came to see me. He is a relatively high-risk patient, and I told him, despite your bladder diverticulums, we're going to do a prostate enucleation, and we will see how you do. If the diverticulums do not pose a problem, a significant problem, and you can empty reasonably and have a reasonable quality of life after the operation, maybe we don't need to treat the diverticulums. Let's see. That would entail a little bit more aggressive surgery, so we did this as a first step. You can see that I'm using the outflow of water, so I fill up the diverticulum with water, and then I use the outflow to carry the stones outside. Luckily, these stone fragments were relatively small, and they could come out. So gradually, I would fill in the diverticulum and then let it empty and bring the stones out. It's interesting to see the inner sheath of the scope. You see it's a metallic tip that I use and I love, and it's a little bit damaged by the laser fiber, and this happens when by mistake you fire the laser with the fiber inside the scope. Luckily, this metallic tip can take it. It is much worse. There's another tip which is ceramic, and this ceramic tip can easily be broken. So when I was doing green light enucleation, I used to do mechanical dissection of the plane with the tip of the scope. Once I was invited to do an operation somewhere, and when I got to the operating room, they had already prepared the patient, and the endoscope was inside already, so I couldn't have a look at the tip of the scope. But it was a ceramic tip, and it was broken by laser blasts. So instead of having a smooth surface, it was quite damaged. It was like a saw, with teeth. And when I started doing the mechanical dissection, I thought, what's going on with this plane? It bleeds all the time. I cannot produce a nice looking plane. And the thing is that I was using a tip that was severely damaged. And that's why I always have a look at my tip before I start the operation, because the patient had a little bit of a rough time because of the bleeding and afterwards. And I realized that if you're going to do mechanical enucleation, the tip of the scope has to be totally smooth and without any possibility of damaging the plane. So that this is one of the lessons you learn painfully. And since then I like much more this metallic tip. In this case, I changed the working element of the laser for the resectoscope loop for a moment to extract the last stones that were a little bit bigger. And then trying to complete the extraction of the fragments. If there are minimal fragments, probably, you know, they could be passed after the operation, but in a man with a diverticulum, I think, or with many diverticulums, I think it's better to be thorough and try to remove all the stone fragments before starting the enucleation. It took a little while, you know, it's about 6 minutes now of surgery, but it's almost done. I think that fragment finally wanted to come out. It was small enough that the loop couldn't grab it properly. All right, you see it's a heavily, you know, trabeculated bladder and with multiple small diverticulums and not so small maybe. A lot of edema due to the catheter. Here I was trying to check that there was no more fragments in the rest of the diverticulums. And yeah, those are the last tiny bits of stone coming out before the enucleation starts. So I think again, well, last look again, there's a resectoscope loop. We always have a resectoscope on the table usually for hemostasis, but it can be useful in situations like this, or even at the end of the operation if there's a residual fragment. Sometimes the loop is good because you can catch it and extract it relatively fast. So the resectoscope keeps being useful, but maybe not so much for TURP, but for auxiliary maneuvers and to complement what we're doing with the lasers. So that's the laser fiber again. And the size of the prostate was about 80 grams, I think. And again, we start with the usual strategy to mark the lower aspect. Sometimes in patients who have been catheterized, it is not so easy to tell where's the sphincter, because after wearing the catheter, the sphincter and the apical limit sometimes is not so easy to distinguish. So maybe that's why I was a little bit conservative here. But that's the sphincter edge clearly there. And that's trying to mark the white line. You see, this prostatic urethra is quite inflammatory because of the catheter, possibly. And we had a lot of mucosal bleeders, and this can be a nuisance at the beginning of the operation sometimes. But I try to complete the white line, deepen it a little bit if it's possible. Here again, I think it's very important to cut these attachments of the sphincter with the apex in the posterior aspect at the apex. That's a small dissecting maneuver. You see, when you do this kind of mechanical dissection, as I said, you have to make sure that the tip of your instrument is smooth, because if it's pointy, if it has irregularities, then you could do more damage than you would want to do. So that's a little bit of laser development of the plane. We know that we are in the good plane, but just developing a little bit further. And again, on the other side, the same maneuver, cutting the fibers that are joining the apex posteriorly to the sphincter, and then entering the plane with a little bit of mechanical dissection, very smooth pushing, and then of course the development of the plane. If you do mechanical dissection, then you will have to do hemostasis later. If you do laser dissection, then the hemostasis tends to happen while you are dissecting. So that's why I have limited the mechanical dissection maneuvers. But of course, sometimes they become very handy and very nice to determine where the plane is. All right. So once there's a single plane posteriorly and a small cavity, I usually put the fiber at 12 o'clock, which is my favorite position, and then I start developing the posterior line of attack. So this line of attack, or this line of dissection, is extremely helpful to know where is the plane, to orient yourself. And you see that instead of deepening the dissection in one point, I like to do very wide movements from side to side to keep a very wide line of attack that helps determining where is the good plane. In this case, the plane develops very nicely, and it's very easy to see how the adenoma is detaching from the capsule. You can see that the fiber, the laser fiber, is trembling a little bit, and this is because I don't use any support for the fiber. I don't use the Cons device, the trigger that allows you to use the fiber as if it was a resectoscope loop. I have my free hand holding the fiber, and this allows me to have a very sensitive control of the tip of the fiber. I can push it in or bring it out with extreme precision because I'm using my fingertips to hold it, and it gives me extraordinary freedom. I went to a course where I had to do an operation using the Kunst device, and I felt severely impaired to carry out this technique because it was somewhat limiting. At the end, of course, I managed, but I love this freehand manipulation of the fiber, and there is some trembling, as you can see, but it's not, I would say, clinically meaningful. I think this tremor of the fiber doesn't limit my ability to perform the operation. All right, so this is the ascension towards one of the sides, you see. So it's very nice to follow the good plane all the way up, but the same way we cut the posterior fibers joining the sphincter to the apex, you have to do the same anteriorly. So this is already quite well advanced. That's a 12 o'clock region. You see all around the sphincter, and following the white line, one has to deepen the incision a little bit first. And then once you have cut 3 or 4 millimeters in depth, then you have to start thinking and searching for the correct plane. This is not going to leave any significant amount of tissue attached to the sphincter, but it will make sure that the sphincter is left behind, it's left distally. You see here, I'm cutting these fibers at 12 o'clock on the other side, and I don't mind of the plane there a little. Just when we are a little bit more inside, then I will worry about the right plane. So this early apical dissection, it's very protective of the external sphincter. You see, this is the white line on the other side. That's the good plane. You see, I'm not now concentrating on the good plane, I'm concentrating on detaching the apex from the sphincter. So I will do this incision in the edge of the sphincter onto the adenoma, you see, on the adenoma. And then once the axis has been established, once we have been able to leave the sphincter a little bit behind, then I will search for the good plane. And this ascending dissection will aim to connect the plane to the other side, to the dissection we did on the other side. So always very careful, always having the sphincter in consideration. We want to do a very delicate access to the plane, but respecting the sphincter, and especially respecting the sphincter's mucosa, because I feel that ripping the mucosa off the sphincter can cause temporary incontinence. That has been reported very often in papers on HoLEP. And the truth is that we have a extremely low incidence of stress incontinence. We don't really anticipate that incontinence is going to happen, and we don't tell the patients they have to do Kegel exercises or anything like that, because in our everyday practice, what we see is that patients do not have stress incontinence after this operation, only very, very exceptionally. And when we have seen patients who tell you, I have incontinence after this operation, it's usually due to a hyperactive bladder. Patients who already were incontinent before the operation because they had this terrible urge to void and to go to the toilet. These patients can have the same symptoms for a while during the operation, but we don't expect to have stress incontinence because the protection of the external sphincter we do is excellent. So that's, you see, the anterior plane. The connection has already been established from side to side. You see the anterior plane is being developed, and the line of attack is now circumferential around the adenoma. So it is possible to follow this line of attack. You see that the plane was very beautiful in the lower aspect, but maybe not so beautiful in the lateral aspect. So it's very helpful to have this line of attack because it orients the dissection very nicely. Of course, you have to know that the plane is going to be circumferential. So instead of doing straight lines, we're going to follow a curved dissection, a curved line, trying to adapt to the shape of the prostate. So you can see how the camera is, or the scope is always trying to keep the line of attack in the middle of the screen, and this gives us the vision of the capsule on one side, on the adenoma on the other side, and one has to concentrate in trying to keep in the good plane. Sometimes it's very obvious that the plane is good because the dissection is very easy, it's very natural, and the characteristics of the plane are obvious, no? And you can see that you are in the right plane and in the right depth of dissection. Sometimes it's not so obvious, and then you have to do your best, and it's a very good help to have this circumferential line of attack, because if the plane is good, let's say 2 centimeters on the right or on the left, or up or down, we cannot be very far from the good plane. So I concentrate on the details, on the information that I can get from what I'm seeing, the characteristics of the capsule, the color, the capsule has a whiter color than the adenoma. I think if you see yellow tissue on the capsule, that's usually adenoma. And with this information that we can get from watching the characteristics of the plane, you can progress in the operation, trying to keep in this interface between adenoma and capsule. I think maybe if you have watched other videos, this is quite repetitive, but this is the principle of this operation. Here we are reaching the bladder neck. We are reaching the bladder neck. And we are carefully trying to find the way to enter the bladder between the adenoma and the capsule. So by following the plane from the sides, coming up, see, it looks a little bit flimsy. Here the danger could be to cut the capsule anteriorly and exit not inside the bladder, but exit anterior to the bladder. So it's also important to acknowledge that we are dissecting a pseudo-spherical adenomatous tissue, and not only the line of attack is circumferential, but also we have to be conscious of the 3D shape of the prostate. So when we are approaching the bladder neck, we have to correct the angle of dissection. And when we are doing the dissection anteriorly, of course, the plane is going to descend towards the bladder neck. In the posterior aspect, where we are dissecting now, the plane is going to start ascending towards the bladder neck. So the idea is that as we get closer to the bladder neck, the fiber has to get progressively closer to the adenoma to correct the angle of dissection. You see here, if you fire against the line of attack itself, there's a risk that you could go inside the capsule. That's why I try to keep the fiber closer to the edge of the adenoma, and not so much firing towards the line of attack itself as I did at the beginning, because the angle of the dissection is changing. You see, we are ascending now. The posterior capsule is changing direction. Now it's ascending towards the bladder neck. So as we progress, it's no longer descending as it does at the beginning. So these are, to me, the crucial points of technique of this operation. You have to know that if you want to dissect the plane and not violate the capsule, you have to keep the fiber closer to the adenoma. You see, always very close to the adenoma. If you dissect a little, then you have to correct and go again close to the adenoma to make sure that the energy is only coagulating the capsule but not damaging it. You see, if you get too close to the capsule and if you fire the laser there, maybe you can penetrate into the capsule. Small penetrations into the capsule are not dangerous, that's not a problem, but if they are bigger, then there could be trouble. This is hemostasis. All the time you spend doing hemostasis is well spent, I think, especially if you do your hemostasis as you progress with your dissection. This is again the lateral plane, coming closer to the bladder neck area. You see the water's now irrigating this space between the capsule and the adenoma, but it's not entering the bladder, because that's why we get so good visibility. You know, one of the trouble people had with HoLEP was bad visibility during the operation, and this technique, the En-bloc technique, really improves this this visibility, because we are irrigating a very small space, the space that we are developing between adenoma and capsule. Here we are getting closer to the bladder neck, but still it is not very clear. You see, sometimes things look a little bit strange and you're not sure where is the entry to the bladder. So one thing you can do is you can go towards 12 o'clock and make a 12 o'clock incision there. No need to do a complete incision, but just a little bit at the bladder neck, and many times you will connect the space, you will connect with the anterior space. Here, I didn't really connect, but just going inside the urethra gave me the information that bladder neck was probably around there, and there it was. All right, so some people are afraid of this step, you know, entering the bladder without any, you know, clear reference. I always say that the direction of the fibers changes there from circular fibers to vertical fibers. But, well, this is a nice tip if you encounter trouble getting in, if you're not sure. It's always prudent to go inside the prostatic urethra and make a 12 o'clock incision to connect. So a little bit irregular surface, but that is now the bladder neck. We have to cut the bladder neck, trying to follow its circumferential shape. You see that my fiber is always at 12 o'clock. I don't like to rotate the scope. I think rotating the fiber is a little bit confusing. Many people do, and that's okay. I think everyone has to find their favorite way, but I think keeping the fiber at 12 o'clock simplifies a lot the handling of the scope and the fiber. So you don't need to rotate, you just need to focus on where you are positioning the scope and the fiber. And also, I think when you rotate the scope, sometimes the camera gets a little bit off. And here, for example, I know exactly where I am. This is 12 o'clock. And because the camera is telling me the truth all the time, all right? So that's why I choose to use it at 12 o'clock. And it's absolutely possible to do the circumferential dissection with the fiber at 12 o'clock. I don't see there's any really significant advantage to rotate the scope. But as I said, this is a personal preference. So that's the lateral plane on the other side, and trying to connect this lateral plane to the bladder neck incision we just made, bladder neck opening. Once the bladder neck is opened, the irrigation of this small space that I was referring to is no longer the same, in the sense that there is now irrigation fluid going in the bladder and coming out the bladder. But also, if there's bleeding, there will be blood going into the bladder, and maybe it's not so easy to take it out, to wash it out as it was before when we were irrigating a closed small space. There's the bladder neck again. It's coming up towards the bladder neck. You know, after some time, this this operation becomes a piece of cake. You know, I think it has a learning curve. I think you have to learn it. You have to get used to the scope and the fiber. You have to get used to the anatomy, which is totally different from what we have seen with TURP, because the TURP had a totally different visualization of prostatic anatomy. And I was remembering Peter Gilling in one congress saying to someone, "You have never seen the capsule of the prostate." I think that was a little bit radical, but of course the anatomy is a little bit different, and you have to learn how to interpret this anatomy. And if you see a lot of operations, I think if you see a lot of videos like this, I think you will get more and more knowledgeable, and you will be better equipped to do your operations. I find that navigating this circumferential plane is something you have to learn and you have to get better at. And that's nearly the end of the enucleation. You can see it's a very fast technique. The sphincter was dissected at the beginning. It was respected completely. And also a fast technique, I think, is a good thing for the urethra. It's a good thing for the sphincter, you know, being able to complete these operations in such a short time. It's been 31 minutes of surgery up to now, and you can see the mucosa of the sphincter has been preserved, and the white line that we marked has been absolutely the landmark that we have respected during the operation. So that's a little bit of hemostasis. I was using the 100 watt console, the old console, and so if you want to change the settings, you have to stop and you have to. So I often try to coagulate with the same settings as I used to do the enucleation, and that means that you have to separate the fiber a little bit more from the tissue to get the coagulative effect. And this is the final detachment of the adenoma. So that's a UO from one side, the UO from the other side, and a little bit final hemostasis. So the purpose of uploading these videos is to try to give those of you who are learning a chance to see many procedures, to see how different the anatomy looks from patient to patient. The quality of the plane is not always the same, and how you have to adapt to that. I think the En-bloc technique is excellent. It's probably easier to learn. You know, when I teach people, I try to do the apical liberation first and then leave them to do the rest of the dissection, because if you think about it, the sphincter is already safe, and you can do some learning. You know, residents and people who are learning can work relatively safely around the adenoma, you know, getting used to manipulating the scope in a pretty safe, let's say, training model. Of course, as I said, you have to see a lot of videos, you have to understand the anatomy, you have to do your cases. I mean, you have to see someone doing the procedure. I mean, it's always better to see the live operation by the surgeon than to see a video, but that's sometimes not practical or not possible. And then, of course, in your first cases, you must have a mentor who helps you. For example, initial cases, someone does the apical liberation, and then you do the rest. And as you get more confident, then it's not such a difficult thing to do to liberate the apex. But of course, it needs some getting used to, and the manipulation of the scope is a little bit different from how you manipulate a scope during TURP. So this is now the change of instrument to start the Morsellation. You see there's quite good visibility inside the bladder, a little bit of bloody medium. So what I like to do is to check where's the bladder neck, and then I would elevate the tip of the blade a little bit to try to keep in the center of the bladder neck. And then I like this situation where I can see the blade, I can see the adenoma on top, and I can see these two black triangles on the side of the blade that tell me that the bladder wall is far away. With these fast morcellators, this is the Perennia system, we can do a very fast morcellation. We measured 11 grams of tissue per minute. So if this prostate had an estimation of 80 grams, maybe the adenoma was 60. Probably in 5 or 6 minutes, the morcellation will be totally finished. So it has radically changed this operation. And if you think about it, an 80-gram prostate with stones in the diverticulum will take around 40 minutes to complete. So it's very, very competitive with TURP, and I cannot find any reason why TURP would be better than this. For example, in this patient, there has been almost no bleeding. We have seen the anatomy, we have removed the whole adenoma, and so I understand it is difficult to change when you're used to doing something, when you're used to hearing that this is the gold standard, but I would like to encourage you, if you don't do HoLEP, to try it. You know, if you don't have a laser, you have to, I don't know, steal it to get one. You know, do whatever it has to be done so you can start doing this immediately. Because these are patients that are super happy. We will remove the catheter the next morning in every patient. Apparently now with the new pulse modulation HoLEP devices, it is possible to have much better hemostasis and remove the catheter earlier, or even you know, not need irrigation, which means that once the patient is ambulant, he can leave the hospital with a catheter, go home, and then come the next day to have it removed in the clinic. So this is opening the path to ambulatory surgery, even with enucleation. For us, it's a little bit difficult because we work in a private hospital, so private patients do not like to be pushed home, you know, with a catheter, and it's maybe a little bit different than public health systems where the patient is a little bit less demanding and more, and he has to obey what they tell him more than in a private environment where the patient has this client, let's say, consideration. No, we have to look after our patients, and sending them home with a catheter maybe it's difficult to explain when they can stay overnight and then have the catheter removed the day after. And here is more or less the conclusion of the case, I think. There's very little adenoma left to morcellate. And that is the fossa. Very nice hemostasis. I hope you enjoyed the case.